Good morning, everyone, and welcome. I'm Dr. Asim Hussein, and I'm glad to have you here today. We'll be discussing infectious emergencies, focusing specifically on necrotizing soft tissue infections, or NSDI, also known as necrotizing fasciitis. Over the course of this presentation, we'll explore the key features, diagnosis, and management of this serious condition. I look forward to sharing this important information with you. Let's take a closer look at the key features that help us identify necrotizing fasciitis. In this case, we have a 54-year-old man with diabetes who developed severe leg pain after a minor abrasion. On examination, there's mild erythema, swelling, and pain that's out of proportion to what we see. His blood pressure is low at 92/55, and his heart rate is elevated at 118. When trying to distinguish necrotizing fasciitis from other soft tissue infections, one of the most important clues is pain that seems disproportionate to the physical findings. This intense, out-of-proportion pain is a hallmark sign because the infection rapidly involves the fascia and deeper tissues, causing significant nerve involvement. Now, looking at the answer choices, fever and raised CRP are common in many infections but are less specific. Leukocytosis indicates infection, but isn't specific to necrotizing fasciitis. Erythema with clear margins suggests a less aggressive process, like cellulitis. The feature that most strongly points toward necrotizing fasciitis is actually pain out of proportion to the examination findings. This clinical clue helps us differentiate it from other less severe soft tissue infections. Recognizing this pattern is crucial because necrotizing fasciitis requires urgent surgical intervention. All right, let's look at the correct answer here, which is C now. An important point to remember is that disproportionate pain is a key early clue in this condition. What makes it so significant is that it often occurs due to deep fascial involvement, which happens before any visible skin changes appear. So, even if the skin looks relatively normal, the patient may be experiencing severe pain that doesn't match what we see on the surface. Recognizing this discrepancy can be crucial for early diagnosis. This insight ties into the overall theme of understanding subtle signs that can lead to prompt management, especially in cases where early intervention can make a real difference. All right, let's look at this slide. We have a question about a patient suspected of having necrotizing fasciitis who is also in shock. The question asks, what is the most important immediate step to take? Now, the options include MRI, surgical exploration, starting IV antibiotics only, a CT scan with contrast, or waiting for culture confirmation. The key here is understanding that necrotizing fasciitis is a rapidly progressing, life-threatening infection. In such cases, time is critical. While imaging studies like MRI or CT scans can be helpful for diagnosis, they are not the priority when the patient is in shock and suspected of having this severe infection. The most urgent action is to control the source of infection and prevent further tissue destruction, which means that surgical exploration and debridement are essential. This approach allows us to remove necrotic tissue immediately, which is crucial for survival. Starting IV antibiotics is important, but in this scenario, antibiotics alone won't be enough without surgical intervention. Waiting for culture confirmation can delay necessary treatment, which we can't afford in a shock patient with suspected necrotizing fasciitis. So, to sum up, the most important immediate step is to perform surgical exploration and debridement. This aligns with the overall theme of early, aggressive intervention in severe infections to improve outcomes. Correct answer, as you see here, is B now. Let's discuss why that is. NSDI, or necrotizing soft tissue infection, is actually a surgical emergency. It requires immediate action. The most critical step in managing NSDI is early, aggressive debridement of the infected tissue. This step is absolutely vital because it significantly increases the chances of survival. Without prompt removal of the necrotic tissue, the infection can rapidly spread and become life-threatening. So, in the context of our overall theme, timely intervention and surgical management, you can see how crucial it is to act quickly and decisively with debridement in cases of NSDI. All right, let's look at this question about choosing the best empiric antimicrobial regimen for suspected necrotizing fasciitis. As you know, this is a rapidly progressing and life-threatening infection, so prompt and appropriate antibiotic coverage is crucial. Now, when selecting empiric therapy, we want to cover a broad spectrum of pathogens, including aerobic and anaerobic bacteria, and also consider the possibility of resistant organisms. Looking at the options, we have flucloxacillin alone, which is good for methicillin-sensitive Staph aureus, but it might not cover all the likely pathogens in necrotizing fasciitis. Then there's piperacillin, tazobactam only, which offers broad coverage, including many gram-positive, gram-negative, and anaerobic bacteria. The third choice, piperacillin, tazobactam combined with clindamycin, with or without vancomycin, really aims to target the broadest range of organisms, including toxin-producing strains like Streptococcus pyogenes or Staph aureus. Clindamycin is particularly important because it suppresses toxin production, which is a key factor in necrotizing fasciitis severity. Vancomycin can be added if MRSA is a concern. Ceftriaxone alone is less ideal here because it doesn't reliably cover anaerobes or resistant gram-positive organisms involved in this infection. Metronidazole alone wouldn't be sufficient either, since it mainly targets anaerobes and doesn't cover the full spectrum of likely pathogens. So, considering all these points, the most appropriate empiric regimen would be the combination of piperacillin, tazobactam plus clindamycin, possibly with vancomycin if MRSA is suspected. This approach maximizes coverage and addresses the toxin-mediated aspects of necrotizing fasciitis. All right, so the correct answer here is C now. Let's break down why this is the best choice. When managing infections like this, it's crucial to use broad-spectrum coverage to target the range of potential pathogens. Additionally, adding clindamycin plays a key role because it inhibits toxin production, which is often a major concern in these infections. Sometimes, MRSA coverage might be necessary as well, depending on the case, but the essential components are broad-spectrum antibiotics combined with clindamycin to control both the bacteria and the toxins they produce. This approach aligns with our overall goal of effectively managing infections while preventing complications. Let's take a look at this question about why clindamycin is specifically added in necrotizing infections. The options here are A through E, so let's walk through them. First, option A suggests it provides gram-negative coverage. While clindamycin is effective against certain bacteria, its primary strength isn't gram-negative coverage, so that's not the main reason here. Next, option B talks about improved renal penetration. Clindamycin does have good tissue penetration, but its renal penetration isn't the key factor in necrotizing infections. Option C states that it treats anaerobes only. Clindamycin is indeed effective against anaerobic bacteria, but the critical reason for its addition isn't just targeting anaerobes alone. Now, option D mentions preventing resistance. While antimicrobial stewardship is important, preventing resistance isn't the main reason for adding clindamycin in acute necrotizing infections. Finally, option E says it suppresses streptococcal toxin production. This is the most important point. Clindamycin has the unique ability to inhibit toxin synthesis by streptococci, which is crucial in controlling the severe, toxin-mediated effects seen in necrotizing infections. So, in summary, clindamycin is added because it helps suppress streptococcal toxin production, which can significantly improve patient outcomes in these severe infections. The correct answer here is E, and I want to explain why. Clindamycin plays a crucial role because it suppresses exotoxin and cytokine production. These are the key factors that contribute to the severity of streptococcal toxic shock. By inhibiting these substances, clindamycin helps to reduce the immune system's overreaction and tissue damage. This is especially important in managing streptococcal toxic shock syndrome, where the toxins and cytokines drive the severity of the condition. So, understanding how clindamycin works in this context helps us appreciate its value in treatment strategies. Now, let's look at the question about imaging in necrotizing fasciitis. The options here are A through E, and we need to identify which statement is the most accurate. First, option A suggests that imaging confirms the diagnosis before surgery. While imaging can be very helpful, we can't solely rely on it to definitively diagnose necrotizing fasciitis before surgery. Clinical judgment remains critical. Option B states that CT or MRI can delay surgery. This is important because, although imaging provides valuable information, waiting too long for imaging results can delay necessary surgical intervention, which could worsen patient outcomes. Option C claims that imaging replaces surgical exploration. That's not quite right. Imaging supports our assessment, but it doesn't replace the need for surgical exploration, which remains the gold standard for diagnosis. Option D implies that the presence of gas on imaging excludes NSDI. Actually, gas can be present in necrotizing infections, but its presence doesn't exclude necrotizing soft tissue infections, so this statement isn't accurate. Finally, option E says that normal imaging rules out NSDI. However, normal imaging doesn't definitively rule out necrotizing fasciitis, especially early in the disease course. Putting it all together, the most accurate statement here is that imaging can sometimes delay surgery if relied upon excessively, but it doesn't replace surgical exploration, which is essential for diagnosis and management. So the best answer is B. The correct answer here is B, and I want to emphasize why. Imaging techniques, such as X-rays or ultrasounds, can be very helpful in evaluating a patient's condition. However, the key point is that they should never delay surgical intervention if the clinical suspicion is high. In other words, if your clinical assessment strongly suggests a need for surgery, you should proceed without waiting for imaging results. The priority is always the patient's safety and timely treatment. This highlights the importance of clinical judgment and experience in guiding decision-making, especially in urgent situations. So, while imaging is valuable, it must not become a barrier to prompt surgical action when it's clearly indicated. Let's go over some key clinical clues that can help us identify necrotizing soft tissue infections. First, pain that feels out of proportion to what we see on the surface is a big red flag. This intense pain often suggests a rapidly progressing infection that's spreading quickly through the tissues. Next, watch for rapid progression of symptoms. Things can escalate swiftly, and delays in recognition can be critical. Hemodynamic instability is another important sign. If the patient's blood pressure drops or they show signs of shock, it indicates a severe systemic response. Late in the course, you might notice skin anesthesia or the development of bullae. Those are blister-like lesions. Sometimes, crepitus, which is a crackling sensation under the skin caused by gas production, appears, but keep in mind it's often a late or less common sign. Overall, recognizing these clues early can be life-saving, as necrotizing infections are aggressive and require prompt intervention. Being alert to these signs helps us intervene sooner and improve outcomes for our patients. All right, let's take a closer look at some of the common pathogens involved in soft tissue infections. First, we have Group A Streptococcus, which is a well-known culprit, especially in cases of cellulitis and impetigo. It's notorious for causing rapid tissue destruction if not treated promptly. Next, we see polymicrobial infections, particularly in diabetics, where multiple bacteria work together, making the infection more complex and challenging to treat. Staphylococcus aureus, including MRSA, is another major player. MRSA, or methicillin-resistant Staphylococcus aureus, is especially concerning because of its resistance to many antibiotics, and it can cause everything from abscesses to more severe infections. Then, we have anaerobic bacteria, which thrive in low-oxygen environments and are often involved in deep or necrotizing infections. Speaking of which, necrotizing soft tissue infections are a severe form of infection characterized by rapid tissue death. Recognizing these key pathogens is essential because it guides our choice of antibiotics and treatment strategies. fitting into the larger picture of managing soft tissue infections effectively. All right, when it comes to immediate management of necrotizing soft tissue infections, time is of the essence. First and foremost, urgent surgical debridement is critical to remove the infected and necrotic tissue as quickly as possible. This step can't be delayed, as it helps control the source of infection and prevents it from spreading further. Alongside surgical intervention, broad-spectrum IV antibiotics should be started promptly to cover a wide range of potential bacteria. Clindamycin, in particular, is mandatory because it not only targets certain bacteria effectively, but also inhibits toxin production, which is vital in these infections. Supportive care in the ICU is often necessary, including aggressive fluid resuscitation to maintain blood pressure and organ perfusion, and vasopressors if needed to support circulation. The goal is to stabilize the patient as much as possible during this critical phase. Keep in mind, repeated debridements are often required because the infection can be extensive and tissue necrosis may continue to evolve. The key is close monitoring and prompt additional surgical intervention when needed. In the context of necrotizing infections, swift, aggressive, and multidisciplinary management is essential to improve outcomes and reduce mortality. All right, let's talk about some common pitfalls to avoid when dealing with necrotizing soft tissue infections. First, do not wait for imaging if your suspicion is high. These infections can progress rapidly, and delaying diagnosis for imaging can be detrimental to the patient. Immediate clinical suspicion should prompt action. Next, do not rely on the LRINEC score alone to make your diagnosis. While it can be a helpful tool, it's not foolproof and should never replace your clinical judgment. Always consider the overall clinical picture, including physical exam findings and patient history. Remember, necrotizing soft tissue infections are emergencies that require swift recognition and management. Relying solely on scoring systems or delaying imaging can lead to worse outcomes, so stay vigilant and act promptly when suspicion arises. Let's talk about pearls for managing necrotizing soft tissue infections. First, remember that surgery is essential. Antibiotics alone just aren't enough to control these infections. When a patient presents with pain that's worse than what you see on the skin, that's a red flag. Think about necrotizing soft tissue infection, or NSTI. If you encounter shock along with signs of a soft tissue infection, this is a surgical emergency, and you need to get the patient to the operating room immediately. The key takeaway here is that prompt surgical intervention can be life-saving. These infections are severe and progress rapidly, so early recognition and aggressive treatment are critical. Always keep in mind the overall theme. Rapid diagnosis and decisive action are vital when dealing with necrotizing soft tissue infections. Thank you so much for your time and attention today. I really appreciate the opportunity to share these insights with you. Remember, the key points we've discussed highlight the importance of understanding the core concepts and applying them effectively. I hope this presentation has given you a clearer perspective on the overall theme and inspired you to take action. Again, thank you for being here and engaging with this material. I look forward to seeing how you incorporate these ideas moving forward.